Good evening, everybody. Today we are going to have the last class of this year, and it has been an amazing 12 months, and we did all the 12 classes, and this wouldn't have been possible without great support from Soumya Kasturi, who had always been on my side. And I would also like to thank Anupam Bambani. And for this interesting case presentation, I hand over the podium to Soumya Kasturi. Soumya, over to you.
Good evening, everyone. Welcome to again, as Dr. Sujata said, the last e-class for Wincars. We are discussing a congenital meets an acquired case, which is a little interesting thing. So the presenter is from Sri Venkateshwara Institute of Medical Sciences, being mentored by Dr. Vanaja. And the examiners are Dr. Anita Saxena from Delhi and Dr. Sejal Shah from Narayan Hridayalaya, or from Bangalore. I'm sorry, ma'am. So both of them are eminent pediatric cardiologists, and they have done such good work in the field of pediatric cardiology. So we'll start the case presentation. Over to you, Sai.
Good evening, madam. Here is a patient by name Sai Muni with age 29 years, male patient heading from Tirupati. Informant is patient only. Chief complaints of shortness of breath on exertion since 1 month and palpitation since 20 days. Patient developed dyspnea, which was insidious in onset initially of NIHA 2 and progressed to the NIHA 4 with and progressed to the history of orthopnea and PND since last 1 week. Patient had history of palpitation since 1 month on and off type and sudden in onset, for which patient attended the cardiac center and reverted with IV injection, no post palpitational diuresis, and no history of chest pain, syncope, swelling of legs, no history of bluish discoloration of skin mucous membrane, no history of fever, joint pain, swelling, hematuria, no history of cyanotic spells, squatting episodes. Past history, no history of LRTS in the past, no history suggestive of acute rheumatic fever in the past, not a known case of type 2 DM and hypertensive. Personal history, married 2 months ago and is a non-smoker, non-alcoholic and takes mixed diet. Family history, no significant family history and is born out of non-consanguineous parentage.
No. Please, can you go back? I think your history slide, just go back to number 2 slide. Next. Yeah. So there are 2 complaints: palpitation since 20 days. Shortness for 1 month, palpitation 20 days. Right?
Yes, ma'am.
Now go to the next slide, and I want you to tell a little more on the shortness of breath. You have said it is started 1 month ago, insidious onset, initially 2, progressed to 4, and now he's got orthopnea and PND for 1 week. So within a span of 1 month, he has become not only symptomatic, he has gone to class 4 and he's also developed PND. Would you like to call it insidious onset then? This is too short a history for somebody to go from, please keep this. Yes, keep this slide. This is too short a history for somebody to go into class 4 over a period of 3 weeks actually. He is already having PND for 1 week. So that's number 1. Please remove the word insidious. Now, I would like to know about dyspnea, about NYHA2 that you've said progressed to class 4 with history of orthopnea and PND. What is his occupation?
Patient was doing I studied up to degree and is doing software job, man.
So has he been exerting before this 1 month? Because I'm very surprised that somebody who was class 2 1 month ago has become class 4. It's a rather short history in my opinion. So was he very sedentary and he didn't realize it? Or it is really that he's symptomatic just for 1 month?
For past 1 month, he is married 2 months ago, madam, and he's that's it, madam. No significant mobilization.
So you were saying that before 1 month he was fine?
He's fine, madam. No past history, madam.
Okay. No, not past history. We are talking of only present history. Was he symptomatic a little bit before that? Or anyway, if you're sure it is 1 month, I'll take it. Now, regarding history of palpitation, 1 month on and off, sudden in onset, for which he attended the cardiac center and reverted with IV injection. When did that happen?
That was happened 10 days back, madam.
So for 10 days, he has no palpitation?
Since from past 10 days, he is symptom free, madam. No palpitation.
Because in your history of present illness, if you go back a slide, you said 20 days. Now here you are saying 1 month.
1 month.
So is it 20 days or 1 month?
Since 1 month, madam, is having on and off type palpitations.
Okay. Now, when we talk of palpitation, we need to talk about relation to exertion, present or not.
Not related to any exertion, madam. No.
Okay. So how long is it this? How long is on and how long is off?
It is few minutes, madam, and for few minutes it's lasting for few minutes, and spontaneously it is decreasing, madam. From past 20 days, this episode was not at all decreasing, madam. So he attended to cardiology center.
Any association with dizziness or loss of consciousness?
No loss of consciousness, syncope or giddiness, ma'am.
With this palpitation I'm talking about.
Yes, ma'am.
Okay, because I think you are not understanding why it is an important history. This is a history of palpitation, and as an adult cardiologist, you should tell me what are the causes of palpitations.
Mainly of arrhythmias, madam.
What are the causes of palpitations? One is arrhythmias. What else?
Cardiac arrhythmias.
One is arrhythmia. Any other cardiac cause of palpitation? Not in him, in anybody.
Other postgraduates can please answer in the chat box.
Regurgitation
What are the
lesions.
cardiac causes of palpitations?
Regurgitation lesions, ma'am.
What do you mean
Valvular heart
regurgitation?
disease.
So any regurgitation will give you palpitation, or there has to be something over and above?
Mitral and tricuspid regurgitations.
Anything mild mitral tricuspid regurgitation will give you palpitations. What is it
Severe
that causes palpitations in regurgitant lesions?
volume overload causes.
Yes, that's the word you need to use, volume overload. So you have two types of palpitations in cardiology. One is arrhythmic and the other is volume overload. How do you differentiate the two? By history, can you differentiate?
Arrhythmic are sudden in onset, not aggravated, no relieving factors.
And volume overload?
They are associated with exertion, ma'am.
Right.
Exertional.
So you when you say palpitations, you need to describe all this. No, your history cannot be that sketchy like you have
Okay.
written.
Okay.
You know, your history actually should run into 2-3 slides, if not more, because history of palpitation 1 month on and off, sudden in onset, for which he attended the cardiac center, reverted with IV injection. You're not even telling us that he hasn't had any palpitation for since the time he underwent it. He had some injection. See, what does an IV injection do to the arrhythmic palpitation? What does it do? What do you think would have happened? I think these are all questions that are for adult cardiology, not for pediatrics. If somebody has arrhythmic palpitation, he goes to a cardiac center and gets an IV injection. What do you think in injection? What kind of injection he would have received?
Mainly nodal AV nodal block agent.
Okay, and then after that, no treatment given. You think his palpitation will go away with one injection?
Palpitations decreased at that time, madam, and is put on oral tablets.
So you never said that, no? You never said in your history that after he was reverted with IV injection, he was put on oral tablets and no palpitations have occurred since then.
Since then, no palpitations.
So you need to say that. No, your history has to be little better than what you are giving.
Okay.
He had history of palpitation for 1 month. 20 days ago, or 10 days ago, he went to the center, got an IV injection, it reverted back. And then he has been on oral tablets.
Oral, yes, ma'am.
Only then I will understand that yes, he had arrhythmia, which got reverted, and then now he's on antiarrhythmic or some drug which is taking care of his arrhythmia. Otherwise, one injection of antiarrhythmic is not going to get rid of palpitations of arrhythmia. That's what it appears from your history.
Okay, ma'am.
Okay.
Okay, ma'am.
Now, I think you talked about, go further. You said family history, you said past history. Go to the past history part. So what is it that you should have asked in the past history? Has he ever been told that he has a heart disease in the past?
No, ma'am. He never had any past history, any episodes for these palpitations previously,
No,
ma'am.
not symptoms. Sometimes they're asymptomatic, but because they have a murmur or because they have something, they go to the doctor and the doctor tells them, look, you have a heart disease. It is not necessarily that the heart disease has to be symptomatic, especially congenital heart disease. So you should say that he is not a known case of congenital heart disease.
Okay, ma'am.
Okay. Has
Not
he
a known
ever
case
gone
of.
to the doctor before these 2 months? Has he ever visited a physician before these 2 months?
Before these 2 months, he visited normally as for fever, cough, cold, like that only.
Hmm. Right. But then at no point he's been told that he has a heart disease. This is
No,
important in young patients. When you have young patients with, 29-year-old, they could be having mild rheumatic heart disease, they could be having mild congenital heart disease, and sometimes they're not symptomatic, but when they visit a doctor, the doctor can hear a murmur or something, and then he can tell them, look, you have a heart disease. So it's important to say that he's not a known heart disease patient. Okay.
okay, madam.
And you should also go next slide. If you're giving a congenital case, you should also talk about, although he himself is the informant, but you should ask about birth history, you should ask about any childhood history, and for that obviously you have to talk to the
Child,
family, maybe his mother or father.
yes, madam. No
Father.
significant, no developmental delay and no milestone delays.
You have to say it. No, you have to write it. That's what I'm saying.
Okay,
You may have
okay,
asked, but unless you
okay,
write, how would anybody know that you have taken that history? That's important past history, especially in a young patient. Next, history where that born out of non-congruent. You should also say how many brothers and sisters he has, what is his birth order.
is second one, madam. Out of two, sister is there with no any abnormality, no
So
disease,
these are the
madam.
things you are supposed to mention in your
Okay,
history.
yes, yes.
You cannot, not mention these things. You may have asked, but you haven't written. So we don't know whether you have asked or not. All
Okay,
right,
madam.
go to the next. Just wait, Dr. Sejal, if
Sai,
you have any question.
Sai, one more thing that you say that the breathlessness on exertion developed a month ago. So you feel that he went to the hospital and got treated with palpitations, but then was he not told anything about a heart disease? So
Yeah,
what
he was
happened to
diagnosed.
the, was that
Yes,
only
madam.
focused on palpitations because he was class 4?
He was diagnosed as and is having heart disease and referred to higher centers for further management at that time.
Okay. And he continued to be in class 4 in spite of treatment. Is that,
Now he is uh, I have two, madam.
sorry? He's in
Now
class
he
2 now.
now he is in class two, madam, with medications.
No, so is that, that medication history, diagnosis history, if you give, will that help you come to a provisional diagnosis?
Okay, madam.
These are very, very important aspects of history that you have not given. We don't know whether it's class 2 or class 4 at this point of time. You never said he's on some medication which has increased his urine output. No, all those things you have totally missed out. I think your history has to be far more. It's not a short case, no, it's a long case. So your history has to be more detailed.
Okay, madam.
So can you tell us what kind of treatment is he on and what kind of heart disease he has been told?
He is having congenital heart disease. He is diagnosed as a congenital heart disease and referred to further higher centers, madam. And using
So
medications
one is, go ahead.
which control the rate
So
for
he is not on any medication which is increasing urine output.
uh, diuretics also given, madam.
So you need to tell us. No, if somebody who was class 4 has become class 2, obviously he would have received diuretic unless his class 4 was all related to arrhythmia, which doesn't seem like because his arrhythmia is gone, but he's still having, he was still having orthopnea and PND till one for a week, you said. So there has to be a column of treatment history. There has to be a column of, course over the last 1 month or two. There has to be a column where he has shown to a doctor and has been told that he's got this heart disease. So all that is missing. Now, show us the next slide. What did you want to tell us next? Before this, can you summarize?
A 29 years old male patient with short history of palpitations and shortness of breath, diagnosed is having congenital heart disease in the hospital.
So 29-year-old with a rather short history of 1 month of class 2 to class 4 with
For
arrhythmic palpitations.
arrhythmic palpitations and orthopnea and PND history.
Do you know what class is PND?
Class 4.
What NYHA class?
Class 4, man.
So do you think PND is included in NYHA class?
Class 3.
Is it included in NYHA? Tell me what is NYHA class 4?
Patient is having breathlessness at rest.
That's not class 4. Can
Tarcopnia.
you tell me the original, verbatim of what is NYHA class 4? What are the 4 symptoms included in NYHA class?
Dyspnea, palpitations, angina, and fatigue.
Right. So it is not just dyspnea, any 4 of these symptoms. Now, when we say NYHA 4, what does it mean? That the symptoms have to be present at rest?
Symptoms present at rest, madam. Yes.
That's not right. Again, these are all things that you should know as an adult cardiologist. What is NYHA 1? What is 2? What is 3? What is 4? 4 is that not able to carry out any activity without symptoms. Full stop. Symptoms may be present at rest. So it's not necessary that he has to have symptoms at rest. Okay, please go and read NYHA 1, 2, 3, 4. Your examiners are very fond of asking exact language which is used for NYHA 1, 2, 3, 4. So please read it, maybe try to remember it, but at least know the gist that class 4 is not symptoms at rest, may be present at rest, unable to carry out any activities. Orthopnea is class 4, but P&D is not classified in NYHA. I hope I've made myself clear to all the students that don't commit this mistake of calling P&D as NYHA 4. P&D is not part of NYHA. You can have an NYHA 2 patient who may still have P&D. I hope it's clear to you, Sai, and to others.
Okay, madam. Yes, madam.
Okay, now tell us, summary is done. Tell us what are the various possibilities coming to your mind.
Sai, what are the situations where you will have symptoms worsening over a span of 1 month and it starts at the age of 29?
Mainly of rheumatic valvular heart disease.
So which lesion can, worsen in a span of 1 month from class 2 to class 4?
Rheumatic valvular heart disease with mitral stenosis.
And what aggravates that? What worsens the situation from class 2 to class 4 in mitral stenosis?
Arrhythmias, infective endocarditis. Mainly of arrhythmias,
The cause of arrhythmia in rheumatic heart disease and mitral stenosis?
dilatation of LA.
Do you think it's acute on chronic?
Main chronic, madam.
So do you have
Acute
anything
and
in the
chronic.
history to suggest that?
No history, madam. Suggestive of chronic.
Okay, so you keep going.
Yes,
What are the
yes, madam.
possibilities from
These
your
are
side? And you can give reasons for that.
the differentials with short history of 1 month palpitations and 1 month shortness of breath, madam. Mainly of congenital acyanotic with left to right shunt with TR and ostium primum AHD and RSOV.
Just one by one. How can ostium primum ASD with TR can give you symptoms from 2 to 4 in 1 month? What is the mechanism? See, you have put a long list of diagnoses. In my opinion, there are very few diagnoses. If your history is correct, then there are very few diagnoses which will fit in your history. So how does ostium primum ASD, which has been present since birth, what happens that in 2 weeks or 4 weeks time patient is class 4? Why should that happen?
MR.
No, MR has been there from forever. It's a chronic MR. No, it's not acute MR in ostium primum ASD.
Arrhythmias, infective endocarditis and infections causing
So you
precipitation.
think he has infective endocarditis? Is there any history of fever?
No history of fever, madam.
So can you get infective endocarditis without fever? If yes, in how many percent?
30% to what?
30% without fever. Let me know what reference are you quoting. Anybody in the students? How often do you get infective endocarditis? See, you get yourself into trouble like this. Because you said infective endocarditis, now you are getting into trouble because of that. Why do you think
10%.
5 to 10%.
It is not even 10%, it is said to be 5%. So it is
5%.
very rare to have infective endocarditis without fever. Your
Without
patient
fever.
has no history of fever. Why do you want to get into trouble by calling it infective endocarditis? I don't understand. If you had said arrhythmias, I think we would have agreed because there is history of arrhythmic palpitations. And only thing against arrhythmia causing so much a problem is because patient, despite having no arrhythmia, is still class 4. That is why your arrhythmias also don't explain the whole picture. So your first diagnosis is out. RSOB we keep, park on one side because I'm going to agree with RSOB. Why do you want to bring cyanotic congenital heart disease like Epstein's and CTJ? What is CTJ with intact ventricular septum? How is it cyanotic heart disease? We are talking a bit of congenital heart now, which I don't know if
Yes,
Dr. Sujata is going to be happy about it, but I think this is as an
Epstein's
adult cardiologist you need
anomaly.
to know. So how does
Yes, ma'am.
Epstein anomaly become symptomatic from 2 to 4 in a 29-year-old?
Epstein anomaly will cause palpitation.
It will cause
Palpitations.
palpitation, but will it produce PND and orthopnea?
No, madam.
What is PND due to? What do you think is the cause of PND? What is the underlying pathophysiology of PND?
There is increased LVEDP causing
LVDP, mitral stenosis, is it increased LVDP?
left and then left atrial enlargement.
Enlargement. Why does
Increased
one get PND? LA
increased
pressure, pulmonary venous hypertension. Why would an Epstein give you pulmonary venous hypertension? Your
Epstein's
understanding has to be right. No, you may commit mistake, but your understanding cannot be wrong. Will Epstein ever give you PVH?
no, no, madam.
And what is the
Epstein's
CTJ with intact ventricular septum? What is that?
causing palpitations and SOB will cause.
So why would a CTJ with intact ventricular septum will give you shortness of breath, that too PND? What is the mechanism?
Due to MR and
Acute MR?
mm,
You have only written CTJ with intact ventricular septum. You haven't mentioned left AV valve regurgitation in this diagnosis. Presuming that you have forgotten to write, will left AV valve regurgitation will give you acute history of just 1 month? Does it come out suddenly from somewhere? It wasn't there earlier.
arrhythmias
It has to be there,
precipitating.
no? It has to. See, you have two symptoms. You have one symptom of arrhythmia, one symptom of shortness of breath.
Well,
You cannot make diagnosis based on one of them. You have to take both into consideration. Class 4 dyspnea in over a span of 1 month and arrhythmic palpitation. These are two cardinal features that you have said. Now, you cannot say my diagnosis for arrhythmia is this and my diagnosis of PND is this. You can't do that, no? You have to put diagnosis which combines both.
okay.
So, of the list that you have given, which is like everything you have given, practically everything you have given in the differential diagnosis, thinking that one of them is going to be right. That's not the way it works.
Acquired congenital, acquired heart disease with CRHD.
Now, why would RHD give you MR, MS, AR? That to everything, MR, MS, AR. You put everything. I don't know why you forgot to write TR. Shunt lesions complicating with infective endocarditis. Again, there is no evidence of infective endocarditis. At least clinically, there is no fever. DCMP, HCM, everything. Is there any diagnosis you have not written? I think this is absolutely incorrect what you've written. You need to know how to write a diagnosis, which diagnosis to consider first. Can anybody else give us a better diagnosis? Somebody else from the students?
There's something, somebody has written RV dysfunction chronic MR.
That is what CTJ, I think somebody has written. But again, if it is chronic MR, why would it give you PND? Either the history is wrong, but if your history is correct, we will have to think about some alternate. I think what you're not appreciating is a short history. And short history with sudden onset of heart failure or PND can only occur because of one, infective endocarditis, number 2, arrhythmia, atrial fibrillation being the commonest, number 3, RSOB.
Okay, ma'am.
And of course, infective endocarditis can cause acute MR, acute AR. It can produce anything which is acute. But then we need to know whether there is infective endocarditis or not. So I think if taking that your history is correct, obviously I will go by what you're saying. I haven't talked to the patient myself. Considering that your history is correct, you don't have much choice.
Yes,
You cannot make any of these diagnoses other than RSOB and MS or rheumatic heart disease with atrial fibrillation. I don't think you can make HCM, DCM. I mean, that way you can even write pericardial disease if you wish to. You're just completely writing anything and everything, including cardiac tumor. But that's not the way it works. And we have to go by your history. We don't have any choice. Your history may be wrong, but your history has to be respected and diagnosis has to be made accordingly. Dr. Sejal, you want to add anything or shall we go
Yeah,
to the
yeah,
exam?
no, I think fine, ma'am. We'll
Coming to general examination, patient is conscious coherent with height 178 centimeters and weight of 96 kg, BMI of 30, upper limb to lower limb ratio is 1:1, is well built, nourished, and no dysmorphic features and no peripheral signs of IE and no spinal and skeletal abnormalities. No pallar express cyanosis, clubbing, pedal edema, and lymphadenopathy. Pulse is 88, regular in rate, regular in rhythm, character, no radio-radial and radiofemoral delay. All peripheral pulses are present. BP of right upper limb 120/80, left upper limb 120/80, right lower limb 130 mm of Hg with a respiratory rate of 16 cycles per minute, thoraco-abdominal type. And saturation of all four limbs are 98%. On exertion it was 90%. JVP was 3 centimeters above the sternal angle with normal wave pattern, prominent A wave seen, normal respiratory variation, and abdominal jugular reflexes negative. Into the inspection and palpation. Chest is bilaterally symmetrical with apical impulse was palpable at intercostal space, mid-clavicular line, occupying less than one intercostal space. Hyperkinetic, grade 2 parasternal heave is present with palpable S2 in the left second intercostal space, no suprasternal or epigastric pulsations, and no scar. Systolic thrill palpated over the left lower sternal border. Percussion, upper border of the liver dullness in the right fifth intercostal space. Left hard border corresponds to the apex. Right hard border is substernal. Left second intercostal space is dull. Trough space resonant. Auscultation, S1 is normal. S2 single widely heard over the precardium with maximum intensity at the pulmonary area. No S3 or S4. High pitched grade 4/6 harsh pansystolic murmur heard over the left lower sternal border. Best heard during the expiration. Short EDM heard over the pulmonary area. Other systemic examination, respiratory system is normal, vascular bed sounds, and CNS no focal neurological deficits, GNR. Coming
Can
to
you
the
go back?
diagnosis.
Can you go back to your findings after the vitals? Go one slide. So saturation is 98%. There is
Yes,
no
madam.
clubbing, you said, no? There's no clubbing. Okay,
No
next.
clubbing.
All right, next. So apical impulse is hyperkinetic. Is it LV or RV type?
LV.
LV, okay. Because you have to first say LV or RV, then it is hyperkinetic or hyperdynamic, whatever word you want to use. Okay. Go to the next one. Next. S2 is single, widely heard over the precordium with maximum intensity at pulmonary area. Is it loud or not?
Loud, yes, madam.
So you have to say single and loud because
Loud.
you're saying widely heard. That means I presume it is loud. Therefore, you have to say loud because if it is heard over the pericardium and I suppose it is heard at the apex also, then it has to be called loud. Now, short EDM heard over the pulmonary area. I think your murmurs need to be explained or described better. Let's talk of the systolic. Grade 4/6, high-pitched, harsh. Can you have high-pitched and harsh murmur? Can the murmur be harsh and high-pitched both?
No.
Usually harsh murmurs are lower pitched, maybe mid mixed frequency or medium pitched. High pitched murmurs are softer murmurs. Classical example of high pitched murmur is an MR murmur or a hypertensive TR murmur. So once you say harsh, it is unlikely to be high pitched. Heard at the left lower sternal border, best heard during expiration. So are you saying that it is not increasing on inspiration? I presume that's what you are saying. Then you are saying short EDM heard over the pulmonary area. Can you describe this murmur a little better? Because each murmur needs to be described in a proper way. Whether it is short or it is long, it is loud or soft. You have to give everything about that murmur. Describe this murmur.
Ejection systolic murmur heard in the pulmonary area.
No, early diastolic murmur.
Early diastolic murmur heard.
And better to call it second left intercostal space rather than pulmonary area, especially in congenital heart disease. You don't know which is pulmonary area. Heart could be all twisted and distorted. So use the word second left intercostal space if you mean that. So early diastolic murmur, second left intercostal space. What else?
Second systolic and crescendo decrescendo type.
Is it early diastolic or ejection systolic?
Ma'am,
you have written EDM, not ESM.
EDM.
Is it ESM or EDM?
EDM.
So can EDM be Crescendo, decrescendo? What
No,
is
no, madam.
EDM?
It's
Early diastolic murmur means it is loudest in the beginning and then it decays over a period of time. That is what is early diastolic murmur. So please tell us about this EDM. Like you've said about systolic murmur, you've said high pitched, harsh, all that. Why don't you say something about the EDM?
it is high pitched blowing.
Okay, high pitched blowing, second left intercostal space. What
Second
else are
left.
you supposed to talk about EDM? Duration. You can have a murmur which is for one less than half of diastole. You can have a murmur which is 2/3 of diastole. You can have a murmur which is whole of diastole, so-called holodiastolic murmur. You need to tell us whether it is increasing with inspiration, decreasing with expiration. So all those things are missing. So this murmur is, you've not described it. And if you don't describe it, then we don't know what are you going to call it. Because all that description is very, very important for you to make a diagnosis.
Okay, madam.
Some people even grade diastolic murmur into 4 grades. Anyway, if you don't want to grade, that's fine. But the location, the duration, the pitch, some people want to say it is heard best in sitting position with leaning forward. You haven't said anything. It's absolutely incomplete description. Have you understood what we are saying?
Yes, ma'am. Yes, ma'am.
Okay, do you want to complete your murmur description or you can't? If you can't, we'll go ahead.
So you
It
want
is
to say something about the second heart sound? You said single and loud.
yes, ma'am.
Is the
Ma'am,
murmur starting with the sound or is this after a gap from the sound? No, all that has to be said.
it's,
Anyway,
high pitched early peaking and incorrect.
there's nothing like early picking in EDM. Sorry. EDM is a murmur which is like a triangle. It starts with a high intensity and then it decays. There's nothing like early picking in EDM. There is early picking in ESM only. So anyway, I think you have to go and read about it.
Right.
So situs solitus levocardia cyanotic CHD. Why cyanotic? 98% saturation, no clubbing.
No, yes, ma'am.
Left to right, post tricuspid level, moderate VSD with obligatory shunt, severe PAH. I don't understand what you've written. Does VSD have obligatory shunt?
No, ma'am.
Do you get obligatory shunt in VSD? What is obligatory shunt? Do you know what is the meaning of obligatory shunt?
So in which situations will you use the word obligatory shunt?
DTGA.
Anybody better from the students?
For survival need shunt. Sudarshan Reddy.
Can you give us an example of obligatory shunt that Dr. Sejal was asking? No, duct-dependent lesions are not obligatory shunts. Pulmonary atresia intact IVs is not obligatory shunt.
DTG.
No. I think you guys have to go and read because you're using these words so loosely that you're getting yourself into more and more trouble. What is obligatory shunt in VST? I don't even know what is obligatory shunt in a VST, which is left to right. What does the shunt in a VSD depend on? Left to right, right to left? What does it depend on?
There are some answers in the chat box. Tricuspid atresia with ASD, DORV, AV canal defect with mitral cleft shunt.
No, AV canal with mitral cleft is not an obligatory shunt. ASD with tricuspid atresia or TAPVC, yes, but classical example of obligatory shunt in acyanotic heart disease is RSOV, where shunt will occur from aorta to RV despite pulmonary artery hypertension. So in a VSD, there is nothing like an obligatory shunt. It depends on the level of pulmonary vascular resistance and of course size of the VSD. So I don't know what kind of diagnosis have you made? Moderate VSD with obligatory shunt, severe PAH. I don't know from where. I mean, I can't even understand what is this diagnosis. Dr. Sejal, maybe you can enlighten me a little on this.
Sai, are you, going back from the echo findings, trying to fit it into your diagnosis? then only you can do that. I don't know if you are thinking that it's a 200% DORV with a restrictive VSD. Is that what is in your mind? The case presentation, we will have to go back to your clinical findings and then sort it out. This is not a diagnosis based on clinical examination, right?
Based on clinical findings only, ma'am.
Okay, tell me one thing. What is your clinical finding? At least you don't jump to the diagnosis, but at least sort out things.
Patient is having
If you go
single
back to the previous
S2
slide, can you tell the
parasternal hip.
source of murmurs which you are thinking they are coming from, and what sort of a situation you feel the child is in?
Patient is having a grade 2 parasternal heave.
No, you don't go back to the findings.
Okay.
Just go to sort of a finer diagnosis, not conclusion, but finer diagnosis. So go step by step.
Maybe
If you think
patient is
S2 is single, widely heard over the precordium, what do you think it is? Because of?
patient is having VHD.
Not like that, Sai. You'll have to say that I think it is severe PH, hyperkinetic PH, obstructive PH. What is in your mind when you say something like this? Or you think it's a truncus? What do you think it is? Single S2 loud, what is it because of?
Hyperkinetic pH.
Hyperkinetic
So if
pH
there is
because of a left.
pH,
Sorry, ma'am.
yeah, sorry. Go ahead, Sejal.
No. Say hyperkinetic pH because of which shunt lesion do you think there will be single S2? Is there any situation where you will have single S2 with hyperkinetic pH?
No.
So then we go back again into S2. If it's hyperkinetic pH, which shunt lesion will produce what sort of a second heart sound? Yes, so somebody has written VSD Eisen-Mengerais single S2. So say only if it's a VSD and it's a pulmonary vascular obstructive disease, your second heart sound will become single.
Okay,
If
ma'am.
it's hyperkinetic pH, your S2 will not become single. So is that what you want to say now?
But there is no future suggest of Eisenmenger. No cyanosis and clubbing.
So
But
what
it
do you
may be,
think is this?
some stage which is little before Eisenmenger. It is still going towards Eisenmenger because S2 is single, and you are saying severe PH. See, there are two findings that you've given us: grade 2 parasternal heave, second heart sound single. So the only condition where you get both these, in fact, grade 2 heave also you don't get in VSD Eisenmenger. So that is also against VSD Eisenmenger. But second heart sound single, if you are taking PH as the cause of single S2, then you have to think about a VSD Eisenmenger. But then you're not fitting grade 2 parasternal heave, you're not fitting grade 4 by 6 harsh, pensystolic murmur, which is better heard on expression. So none of your findings are actually fitting with that. So I don't know what diagnosis you want to make.
VHD going into Eisenmenger.
VSD is going into Eisenmenger, then why do you get such a loud systolic murmur? If the VSD is shunting bidirectional or is hardly any shunt because the pressures are equal, then why should there be such a loud systolic? I mean, there is systolic murmur as well as a thrill. You've said even a systolic thrill, and you're
So,
calling it a VSD murmur because you're not calling it a TR murmur because the murmur is increasing on a expiration or better heard on
Expiration.
expiration. So it cannot be TR also.
so what do you
Only
think
we-
the murmur is caused because of Sai? What is the source of
Murmur,
systolic murmur?
left to right shunt VHD, madam.
So what causes the left to right shunt across a VSD? Like what ma'am explained,
Pressure.
that the flow across the VSD is related to what? It's because of what?
Pressure.
Is it pressure? So you think there's a pressure difference between left ventricle and right ventricle?
Yes, ma'am. Is restrictive.
The VSD is restrictive?
Yes, ma'am.
Okay, so what is causing the PAH then? You understood, Sai, what I'm saying?
Yes, ma'am. Yes, ma'am.
If the VSD is
Yes.
restrictive, you have a pressure difference between LV and RV. That means you want to say the RV pressures are lesser than LV or more than LV?
Less.
RV is lesser than LV. And the flow across the VSD is related to what? What causes the VSD to flow from LV to RV? Say, in a VSD, what causes the flow? Say you want to on the video. I think it's better that we interact and,
Yes, ma'am.
try to understand. Yeah, what causes the flow in a VSD? You say left to right. What decides the flow that it happens from left ventricle to right ventricle?
Pressures.
So basically, it's not the pressure. See, for example, if you have a large VSD and LV and RV pressures are equal, you can still have flow from left ventricle to right ventricle. That happens because of what? You know, in a large
Size
VSD
of the
at birth, there is no flow. Why is there no flow at birth? Then at 3 months, the child comes in failure. And then at 10 years, we say he is mingerized. There is no flow. So why is there a difference in these three ages?
size
There's
of
an
the
answer in the chat box which says PVR,
Yeah.
which is what I think Dr. Sejal was trying to ask you.
PVR. Yes.
It is not pulmonary pressures, it is
Pulmonary
PVR,
vascular
pulmonary
resistance.
vascular resistance. So please understand the difference between PAH and PVR. Everybody, all the three ages that she said will have PAH, but the PVR is high at birth. PVR comes down, patient gets into failure because the flow increases, and PVR starts to rise again at 5 years, 6 years, 10 years, and the left to right shunt decreases. So it is PVR which determines the degree of shunting.
Okay, ma'am.
So then coming back to the situation, you feel the LV pressures are higher than RV pressures and RV pressures are lesser, then what is causing severe PAH?
So
Isn't
one
it?
of your findings has to be incorrect, either the murmur or the second heart sound. You can't have severe PAH, even if the PVR is low, you cannot have severe PAH with a harsh grade 4 systolic murmur in a VST. For a murmur to be there, which is so loud, there has to be a gradient between LV and RV. And therefore, your RV pressure should be normal or slightly elevated. So you cannot have PAH severe and a loud systolic murmur. Understand that. One of your finding is incorrect. And what is this EDM due to? What is the cause of EDM in your diagnosis? You can go to your diagnosis now and tell us why there is EDM. Because I don't see any reason for EDM in your diagnosis. You said there is an EDM. Where does it figure
EDM.
in your diagnosis? Where does it figure in your diagnosis? What is the cause of EDM? What are the two important causes of EDM in anyone?
PH and
Not PAH,
PR.
PR. And what is the other cause? Commoner cause? AR.
Yeah.
So you have to write something in your diagnosis. Is it AR or PR? You have to commit.
Can you differentiate that, Sai, clinically?
Based on the site,
I think we are running short of time. Let's go to the
Yeah.
investigations then, because I don't think the diagnosis is correct at all. Even normal sinus rhythm is not written in your diagnosis, which should be part of your diagnosis. Okay, can you read this ECG?
so it's a normal sinus rhythm. ECG show with counterclockwise loop, with left axis deviation with QRS axis of -20 to 30. Yes, ma'am. This is, the poor R wave progression also there, ma'am.
What do you mean poor R wave progression? Are you seeing any R wave till V6? This is not poor R wave progression. There is no R wave. Almost no R wave till V6.
No R wave, ma'am.
When you have poor R wave progression, you do get some R wave in V5, V6 at least. Here there's hardly any. So this is the abnormal QRS complexes, or monomorphic if you wish, if you want to call it monomorphic QRS from V1 to V6. Okay, X-ray.
Tachycardia is
Okay, so this is the ECG during tachycardia. What does it show?
atrial fibrillation.
It is fibrillation or something else? Why do you say fibrillation? Because?
Irregular in the
Okay.
absent of T waves. Atrial
So very fast heart rate. You should say with fast ventricular rate. That's the first thing. Then irregular RR.
fibrillation. Yes, ma'am.
And then, of course, you could probably see fibrillatory waves, although at times I don't know whether it is flutter also or flutter fibrillation kind of a picture. But RR is irregular and there is fast ventricular rate. Okay.
X-ray, the slight rotation is there, ma'am, with dilated P and straightening of pulmonary bay, increased pulmonary vasculature up to the distal and RV type of apex. Cardiothoracic angle also increased. Cardiomegaly.
So you go to the heart, then you go to the lungs, then you come back to the heart. I mean, this is really not the way to read an X-ray. You have to finish heart first, then go to the lungs. You can't keep on going back and forth. Is there any evidence of PAH? What is the quality of this film? Tell us, is it a good quality film or no?
No,
Why not?
more penetration, white,
Is it more over penetrated or under penetrated?
over penetrate,
If it is over penetrated, you should be able to see the spine.
under penetrated.
Yeah, it has to be one of them. Anyway, so does this help you in your diagnosis?
This is RV type of apex with
I'm
increased
not sure if it is
cardiothoracic.
RV type of apex. It could be LV also. You said clinically also LV apex, no? Hyperkinetic apex, LV type. Even this could be LV apex. I'm not sure. It's not uplifted apex. So it could be left. But there is some cardiomegaly. There is definitely cardiomegaly and there is increased vascularity.
Increased
So it
vascularity.
goes with a shunt lesion. That's all we can say. Next, do we have anything like an echo or something? Okay.
Echo. There's an left to right shunt with increased flow. Suggest of VST.
Anything else in this echo?
Dilated
Dilated?
Which view,
Yeah.
which structures?
short axis
What view is this?
uh, four chamber view.
Are you seeing mitral valve? In a four-chamber view, you should be able to see LA and LV
Oh.
and a mitral valve. You don't see it here. So it's a distorted view. It's not a four-chamber view.
Okay.
Next. So you're not open. See, mitral valve is not opened here. Similarly, LV is hardly seen. What you're seeing is just a VST.
VST.
Or maybe two, I don't know. Probably two VSTs. Do we have more views?
Yes, ma'am. Gradient. Parasternal long axis. The iota is not seen.
Iota seen, it is overriding. It seems to
Override.
be overriding, or it is probably originating from RV. I don't know. Not very clear, but it may be originating from RV to some extent.
Yes, ma'am.
Next. Sometimes adults don't have very good windows, so you may not be able to see very well. But clearly there is a left to right shunt, and perhaps
Yes, ma'am.
aorta is not from LV totally. It may be DORV or overriding. Next.
VST.
Yeah, it's the same thing that we are seeing again and again. We don't have more information. We don't know what the pulmonary artery is coming from. Next. So this is probably RV or let's say pulmonary arteries with pulmonary regurgitation.
This is the only image which we could get of both the great arteries, ma'am. He was a
Right.
hefty.
Yeah.
Sorry for the
Yeah.
poor one.
No, I can imagine. I think it's tough to image such people. Okay, next. Okay. This is pulmonary
VST.
regurgitation.
Yes, ma'am.
Yeah, quite high.
Yes, ma'am. So sorry for the poor images. It was like a DORV with an aorta overriding the VSD of around 120 because we were not able to image very well. Ma'am, you want to see the CT or CAT data, ma'am?
If you have cath, I think that will help. Because it looks like a restrictive VST,
Yes, ma'am.
or at least there is a gradient between LV and RV, and therefore LV pressure should be actually quite high, higher
Yes,
than
ma'am.
RV pressure, and there is severe PA. So it's like a typical example of DOR with restrictive VST, where you can get a good murmur along with PAH, but
Yes,
not in a straightforward VST. That is what we were objecting to. Large VST by itself cannot give you grade 4 murmur and PAH. Whereas
yes,
over here you are getting DORV with restrictive VST, which is giving you a murmur At the same time, there is severe pulmonary arterial hypertension. And yeah, you have the pressure data here. LV is 180
Yes, ma'am. And also the
as
parasternal.
against RV of 100, as against RV of 100.
Yes.
So it's DORV with a restrictive VSD.
Yes, ma'am.
And that is what is obligatory shunt. So I think, Sai, you probably, somebody told you the diagnosis in your ear and you were trying to fit in your findings. That never do that, because you will never be able to answer any questions.
We have
Okay,
done
anything?
some 3 angios, ma'am. You want to see
Yeah,
the
yeah. Let's see. Let's see. Yeah.
He's also seeing the angios for the first time.
You told him the echo diagnosis. That's why he's.
Madam, we'll talk about it later.
See, this is what happens. No, that is what I keep saying, never know the diagnosis, because in the exam, like I will definitely pass somebody whose diagnosis is wrong. I will not mind not passing that person, but I will definitely not pass somebody who is not able to make a diagnosis based on his or her findings. Because what we are checking in our exam is how the student thinks. What is his understanding of hemodynamics? We are not checking whether he's missing a systolic murmur or making a diastolic murmur. I don't care about that, because we have echocardiography now. So I'm not much worried. But I think the understanding of hemodynamics, understanding of how murmurs are produced, understanding which murmur where is very, very important. And if they fail in that, then there is a big problem. And that is why I always tell them, don't ask for the diagnosis. If you know the diagnosis, you try and fit your find. Either you should be clever enough to fit it. If you are clever enough to fit it, that's fine. But if you are not, then you get into a soup. And that is very bad, because it gives a bad impression to the examiner that somebody has told him the diagnosis and he's trying to, make that diagnosis. That is what is happening here. That is what is not right. Okay, do we have NGOs? Are you wanting to show us NGOs? I think this is RV NGO only.
Yes, ma'am.
Do you have an LV NGO? Because that will
Yes.
give us the diagnosis. Yes.
Again, the injection was anemic. We gave 25 ml of contrast.
Yeah, he's a big fellow. Yeah. So unfortunately, we are not filling that restricted VSD or the great arteries because of the dye not being adequate in a big fellow.
Show you the CT.
But I think your pressure data is pretty very, very convincing of DOR with restrictive VSD. What was his PVRI?
Ma'am, PVRI was 5.6, ma'am.
Okay. I think whatever his PVRI is, he should be operated, because he's got obligatory left to right shunt. His PA pressures are still, I mean, they're going to be high. We know that, but he still should undergo surgery.
Yes, ma'am. It's just the CT to show that LALV is volume overloaded.
Yes.
Intact interatrial septum, pulmonary veins are big, indicating brisk pulmonary venous blood flow. Both arteries are from the RV, side by side, aorta to the right, PA to the left, and almost unobstructed pulmonary blood flow.
Yeah. I think his ECG, if you had done V7, V8, you could have picked up LVH, because his X-ray is quite good. It shows cardiomegaly, plethora. So I think all that favors that he's operable despite severe pulmonary arterial hypertension. Very nice.
This is that VSD, this thing.
Yeah, quite small. And that's the only outlet for LV.
Yes, ma'am. That is why he had that heave, thrill.
Right. Yeah. No, his findings were quite typical. Only thing is that I still don't know why he went into pulmonary edema, PND, unless arrhythmias pushed him into that.
Fibrillation might be one. That might have been the reason.
I think that must be there. But once his fibrillation was better, his heart rate was controlled. In fact, he should have come out of pulmonary edema, because the candidate said that he continues to be class 4 even after his arrhythmia has gone, was something very unusual.
He's class 2 now. His discharge to home, we told him about the surgery and all. They're still contemplating about it. We'll operate him sometime next month, ma'am.
Right.
Sai, do you want to read the final diagnosis?
Yes. Situs altus levocardia with DORB, large perimembranous VSD being restricted by with gradients of 120 mm, side by side, great arteries, aorta to right, unobstructed pulmonary, severe PIH, and good biventricular function, sinus rhythm, no evidence of infective endocarditis and CCA.
But you have to write DORV because just a VSD being restrictive will not give rise to this picture. It has to be
Okay.
DORV with restrictive VSD. You must understand that LV has only one outlet, which is VSD.
Mhm.
Therefore, it has to be, aorta has to be from RV.
Yes, ma'am.
So there's a question, should he undergo EP study? Because his ECG appeared like flutter. But I would perhaps think that if he is in sinus rhythm, he should recover after surgery. In fact, his arrhythmia should not recur after surgery if we have taken care of all the hemodynamics and the LA size and all that. Okay. Anything else, Dr. Soumya, Dr. Sujata?
I put the thank you slide.
Thank you. Thanks, Soumya. Thank you so much. Okay, so I hope everybody learned, not just Sai, all the students.
Thank you.
Yeah.
I think the main message that I would like to give here is again the same, that please make your diagnosis based on your findings, not on somebody else's findings. You must be able to explain your findings with your diagnosis. I wouldn't even mind calling him a VSD PS with your finding, although I cannot explain arrhythmias and PNDs and all that, but a person having second heart sound and a grade 4 single and a grade 4 systolic murmur, very odd for a VSD. Very odd for a VSD.
I think it was a
Mm.
difficult case clinically to
Yes.
fit into something directly unless and until you know the diagnosis.
Yeah, that's what I'm saying. Clinically, I would perhaps make it VSD PS
Mm.
rather than PAH. Because you can have DCRV like picture where you have a very low systolic murmur, which may appear like a VSD murmur, but it could be DCRV or a low obstruction in the RV. Because if second heart sound is single, then I don't know what else to make.
Thank you, Dr. Anita Saxena, and thank you, Dr. Sejal, for patiently being with us and teaching all the postgraduates so many things. We would really like to have you as guest lectures again and again for the congenital heart sessions. And for the adult cardiology PGs, pediatric cardiology is very interesting. Please go through the cases. And because this is the last session of Wincars for the year, Happy New Year, everybody. Have a great year ahead. Thank you.